Health and Environmental Services. Jen Hadayia is a senior policy planner, and Dr. Patricia Cummings is the manager of our newly minted, oh my goodness, Built Environment and Health Impact Assessment Unit. So please join me in welcoming them today.
So yesterday at the conference, one of the speakers used a term that I just loved. He said the word, or coined it perhaps, super indicator. If anyone was here and heard that. And the idea of this is a fulcrum, a tipping point, where you could focus and in that theory of change create scaled up, widespread improvement. And if I can, I'll probably steal that term because I think it perfectly describes the work we're doing at Harris County Public Health in that litany of happy, healthy, prosperous communities to improve health on that grand scale, the go big or go home scale we heard about yesterday as well. So I will posit to you that what you'll hear about today in terms of what we call health equity and the way we are approaching it is that super indicator. If we can tip that in the theory of change, we will see that go big or go home improvement. And what Ellen is passing around right now is and I realize it's double-sided, check that out, is the summary of this super indicator. So I'm going to start pointing that. So one thing we've also looked at or seen a lot at this conference are maps. And so it reminds me of all the maps I've seen around the super indicator of equity and how we measure the happiness, health, and prosperity of a community. And so I wanted to start with this map because I think this is one of the best representations of this approach that we're using to make that scaled up change. And this is a map of a very simple metric, which is life expectancy, average life expectancy in one city. And there are maps for many, many cities like this. I picked this one because this is a city I actually lived in for several years. This is New York City. And what this map shows you are the differences in place for how long, on average, somebody lives there. And we're not talking about massive differences in the place. We're not talking about city to city. In this map, it's the difference between a subway stop. So if you look in the middle, 76 years, that's where I lived. It's up near Morningside Heights in Harlem. Average life expectancy is 76 years. A couple subway stops south, 84 years. Why such a big difference? And you start to ask yourself those questions of, in just the matter of a few subway stops, why are people not living as long? And that's where we start having conversations around that super indicator of what truly causes health, what truly makes communities happy, healthy, and prosperous. And so we're going to talk to you today in our tag team about how HCFES is trying to answer that question, how we approach it from a theory of change, how we find solutions for it across Harris County. So, with that, this is us. And here's what we're going to talk about. So, what are the true drivers of health in a community? What's our health equity footprint? So if we know what drives it, where are we? And then how do we approach change? And at that point, I will pass it over to my colleague, Dr. Cummings, who will talk to you about healthy, sustainable community design and the focus of our new unit at HCFES, which is Built Environment and Health Impact Assessment. I'm making sure I'm pointing right. So the first thing I want to do, though, is clarify some definitions, because these two terms often get used very interchangeably. And in the way in which HCFES is approaching this work, we define them very differently. They are not interchangeable concepts. And the reason I emphasize that is because the solutions are very different, whether you're talking about disparities or you're talking about inequities. So I always want to start here with clarification of terms and some common understanding of what we mean when we talk about a super indicator of health equity. So first, a disparity is a difference in a health-related outcome based on social determinants. So age, sex, race, gender, where you might live, those are just differences based on those outcomes. They might happen for any number of reasons. It might be random, it might be unavoidable, it may be something that's in our physiology and we can't change it. As opposed to an inequity, which are the same differences, but they're not random by chance, they're not unavoidable, They're caused by historic or systemic patterns in how those social determinants have been created. They're caused by the choices that are being made at a policy level, by institutions, by organizations, which also means they can be fixed. So the quintessential example here, which you see quite often, is about birth weight for babies. So it is known that male babies are born at a heavier weight than female babies. It's physiological. It just is a biological fact. That's a disparity. It's different. It's a difference based on determinants. But we also know that African American babies are more likely to die in the first year of life than white babies. Not caused by chance, not caused by physiology, caused instead by the social determinants of African American women and their children and their families in neighborhoods that we've created. We've created those policies, those laws, those decisions. Issues around access to care, lack of resources. I'm going to skip this one for time. So, just to make that distinction about what we're talking about. So how much do those determinants actually matter? How much does it matter what those policy or decision-making outcomes are? Well, these are two sources that something happened. But you can kind of see there's little people on there. So these are two data sources that I use as my seminal foundation for making the case for this to be that super indicator. Why is it such a tipping point? Well, these are analyses that have been conducted to actually show the number of, preventable deaths every year due to things that are within our control, like poverty, racial segregation, lack of the social connectedness that we've talked a lot about at this conference, income inequality, and then physical attributes in our environment, how clean is our air, how clean is our water. And you can see, the values aren't there, but it's something in the millions of preventable years of life lost because of these conditions which we control. So if we truly wanted to have that tipping point of improving health outcomes, we would improve air pollution and we would fix education, because those are truly what's causing the most avoidable deaths in the United States and globally. So, to summarize, social and physical determinants of health account for half of all health outcomes. Half. And that can be good or that can be bad, depending on what those choices are. What does it look like here in Harris County? Well, these are two maps that just came out this year. This is from a source called the County Health Rankings. So if you're ever trying to find out where any county in the country sits on a range of measures in terms of being happy, healthy, prosperous, this is a great source for that. And I've circled Harris in both of these. And they have measures on health outcomes, so, hypertension, diabetes, all those things we think of very specifically around clinical health. And they also have a measure of health factors, behaviors, access to care. And you'll see what our rank is in both. We're 50, number 50, that's actually on the top end. There's about 237 counties ranked in County Health Rankings. We're 50 for Harris County when it comes to those health outcomes. But we drop almost twice as far down when we look at health factors. And the difference between the two are the social and physical determinants. What makes the difference in these rankings happen are things like poverty, income inequality, racial segregation, lack of education, poor physical and built environmental conditions. That's what's dropping us in these rankings as a county compared to the entire state. Now, our specific jurisdiction at HCFES is the unincorporated areas of Harris County and independent municipalities. So I wanted to at least spend a little time talking about what our footprint in our jurisdiction looks like on some of those key factors. And some of them are better than when you include the city of Houston, but some of them are actually worse. But here's our unincorporated county health equity footprint, if you will. We have 13% of people living in poverty in unincorporated Harris. We have 19% of children living in poverty, 7% unemployment, higher than the state rate, by the way, and then 71% of men and 73% of women without college degrees. So with that achievement gap in education. But when you start to look at specific areas, specific places of unincorporated Harris, you see some data which are a little troubling. The percent of children in poverty in some of our communities in our jurisdiction increases 1.5 times the county average, including the city of Houston. And unemployment in some of those unincorporated areas increases almost 2 times when you include the city of Houston. So we're looking at some pretty significant underlying causes of health in unincorporated areas. I'm almost done. Okay, so here's our approach. This is where I'm going to sum up, and I'm going to go really fast. So our approach to addressing the super indicator, if we really want to change the conditions, go big or go home for health outcomes in Harris County, this is what we do. Public health actions that transform the root causes of health, and those are these 4. We call them the 4 E's. They're easy to remember. Economics, education, environment, and engagement. And we believe that if we can make change in those 4 upstream causes, we can impact all the downstream outcomes. And this is somewhat revolutionary, transformative in the public health world, because this isn't the traditional approach to public health outcomes by doing economic development, community development, built environment, community engagement. But we believe that if we can do this, we're going to change that super indicator. So here's a few examples of what we're doing. First, we have to transform our own house. So we're in the process of organizational transformation. We have just adopted a health equity policy for the entire organization, so that health equity is the lens through which all of our programs look on a regular basis. We're also training our staff to understand why this new direction. What do we do to make change at that go big or go home level? We're also launching very specific place-based equity initiatives in some of those communities where those social determinants are 1.5 to 2 times greater. One of them you'll hear from my colleague at the last part of this session. And we're using data analytics that can scan for inequity. So we're actually looking at public health data for the first time through the lens of economics, education, environment, and engagement. So we can find where those needs are. This is one of those initiatives I wanted to focus on. You saw the slide yesterday in one of the keynotes. They put up Healthy Living Matters. That's one of our initiatives to change policy systems and environments around those 4 E's. And the Build Health Partnership is a new initiative. You'll hear about that if you stay, so please stay. But then we also, as you mentioned, have a new built environment unit. And if my part of this presentation is the why and the what, then Dr. Cummings is going to tell you the how. How do we do this? How do we create happy, healthy, prosperous communities that are equitable through this lens? So with that, I'm going to turn it over to her. And you need this.
So that was a perfect segue into how we're doing this. Our new unit was created in January, and Alan Schwaller is part of the unit. So public health is starting to integrate with planning and urban planning. So Alan Schwaller, and we have another person on staff that both have urban planning and design backgrounds. My background's in epidemiology, and so it's this perfect mix of sectors that can work to make these transformative changes in our environments. And so when we're approaching community design and when we're starting to work with planners, engineers, and architects, we try to make places and planning our communities so that they are designed in a way that make it easier for people to live healthy lives. And so that's essentially linking destinations that promote health, such as schools, parks, grocery stores, and workplaces via transportation networks, and that facilitates safe travel for all persons of all abilities. So people that are in wheelchairs or can't get around as easy as others. And so when we're approaching this problem, we have to think of why. Well, why do we need this? There's a lot of data that suggests that our environments influence our health. And so one of the ways that we do this is through community design. So currently, the statistics show that less than half of U.S. adults meet the current U.S. Physical activity guidelines, which are about 150 minutes of moderate activity per week, so it's about 2 hours and 30 minutes, or 10 minutes of brisk walking 3 times a day, 5 days a week. That's a CDC recommendation. Fewer than 3 in 10 high school students get at least 60 minutes of physical activity every day. So these statistics are very sad, but that's the reality. And because of these statistics and because of all these environmental factors, we are suffering from so this is obviously costing us a lot of money. And you know, we used to think about the problem of tobacco and public health being insurmountable. And we've actually made tremendous success with tobacco. We still have too many people that smoke, in my opinion, but we've made tremendous success since then. The problem of obesity to me feels really insurmountable, and it's costing us about $1/5 of $1 trillion, about 200 billion across the U.S. per year. And diabetes alone, which is can be a result of overweight or obesity, has doubled in the past 15 years, and it's costing us 2% of our GDP. 2%. Okay? If you think about that, that's a lot of money, and this is just, it's a crushing economic impact, and one that we are really in public health trying to address. So these statistics are astounding, and ones that are why we're investing so many of our dollars in strategic planning, starting to move towards a more preventive approach through our environments and through policy systems and environmental changes. So one study that I like to bring up measured the effects of urban sprawl communities. So they looked at people who live in counties marked by sprawl style development, and these are spread out homes that are far away from other destinations, and you essentially have to get in your car to get anywhere. And they found that people that lived in sprawl style developments were less likely to walk, more likely to weigh more likely to have high blood pressure, and having high blood pressure leads to subsequently other chronic conditions such as heart attack and stroke. So I love this slide because I always make everyone stand up during this slide. Physical activity, everyone can stand up. Everyone take a big stretch up. Take a deep breath in. All right, stay standing for this slide. All right, so we know that a sedentary lifestyle is a primary risk factor in cardiovascular disease, stroke, and all causes of death. And so regular physical activity is very important for maintaining good health. So having those environments and having those policies in place, even workplace policies, to encourage people to do 10-minute brisk walking 3 times a day is really important for our health. So at HCFES, we are promoting the use of walking meetings. So I encourage you to take that idea back to your workplace and just take a quick 10-minute walking meeting. Ellen and I do it all the time. We walk around our building or walk down the street, even though there are no sidewalks. We walk in the street. And this just helps get our blood pumping. It helps you with creative thinking. So I really encourage you to do this. It's something that we're prioritizing in our organization, and we're hoping to promote it. There's also a great resource. If you just Google Instant Recess, there's a lot of great activities that you can look and take back to your organization. So communities that are designed to encourage people to walk and bike to school or work while completing daily activities and errands, such as going to the grocery store, can contribute to meeting that CDC recommendation. All right, you can all sit down. I'll let you off the work. So in terms of active transportation trends, what you see on this graph is really reflective of what you see on a national and even a continental scale, and it's an inversion. In 1969, the odds are you walked to school, only 12% of the population was driven to school. In 2009, the odds are that your child is driven to school. So only 12% of the population in 2009 walks to school. So in one generation, we have completely inverted the way we move about our community. And what does this mean? And why does this really matter? Well, it matters because of this. We know in literature, in the scientific literature, that studies support these associations. So physical activity, we know that if there's low physical activity, it leads to overweight, obesity, cardiovascular disease, and a plethora of other diseases that are subsequent from that. Air quality. If we're not creating environments that are walkable, bikeable, and easy to move about without a car, we're increasing our air pollution and our carbon footprint. great presentation, Dr. Nanda across the way talked about lighting in hospital rooms and how that improved their ability to recover quickly. And so it's really important, these connections, that we're creating built environments that support these. And so green space and mental health, so our keynote also mentioned Japanese forest bathing to reduce stress, and then the UPenn Philly study of greening vacant lots, and that resulted in reductions in crime. So all of these factors in our built environments are connected. So I want to just talk a little bit about what public health is prioritizing right now on a national scale, and also within our I use HCFES, that means our health department, by the way. Public health and equity principles for transportation. So encourage transportation and land use planning policies. So one example of that is complete streets policy. So our unit is working with our public infrastructure division in the county to look at ways that we can put in some complete streets strategies. Establish performance measures to promote safe, affordable, and equitable public transit and alternative modes of transportation, and specifically looking at walking and cycling for persons of all abilities. Use of health impact assessments to inform and guide policy projects and planning. And I'll talk a little bit more about what HIAs are and exactly what our unit is doing. And fostering participation among local communities and underserved populations throughout the planning process. And some examples of that are photo voice or using interactive workshops. Photo voice is a really good way to engage the community, and that translates into a really powerful way to speak to policy and decision makers. They say a picture is worth 1,000 words. It's very true, especially when you're trying to inform your policymakers about issues in your community. So I just want to briefly mention some of the interactive workshops that Ellen has actually done with Place It. Is that Place It? And they do some really creative things to engage children and adolescents. And one of the ways is through interactive workshops. So a school classroom can have children think of things that they want to see in their community, things that they want to do or enjoy doing. And if you're interested in hearing more about that, you can talk to Ellen after she knows all about it. And expand funding of community-based transportation programs and services that promote health. So services to healthy foods and water and affordable housing, employment, and schools. And then designing and constructing multimodal transportation systems within each state and metro areas. So here are some tools, and I'm going to go quickly through the first one. So what is health impact assessment? Essentially, it's a structured process that uses scientific data, professional expertise, and stakeholder input. And we use this to evaluate the public health and health impact of policies, projects, or plans. And we do that through 6 phases: screening, scoping, assessment, monitoring, and evaluation reporting. And essentially, what this does is it looks at a policy or plan that's coming down the pipeline that decision makers have brought to the table or have proposed. And we look at it and determine if policy or plan or project will have a substantial health impact on community that project is approved for. So a good example of this is a freeway expansion. We would look at all the neighborhoods and population that are living along that freeway expansion and see what the health impacts are of that policy or proposed plan. So there is a local example. Jay was involved in the Houston Transit Oriented Development HIA, so I encourage you to Google and look it up and read it. But I just wanted to take you quickly through how we would propose an HIA for a problem like this. So the problem is, and I've sort of simplified it, I'm sure there are a lot more issues, but only one operating rail line in Houston, and given the population growth and this expansion, is placing demands on our roads, so that results in issues in traffic and access to services. And so proposal, let's build some new rail lines that will connect downtown Houston to all these different areas, right? Great, they have a solution. Not so fast. Well, why don't we first think, okay, well, what are the health impacts of doing those railway expansions, positive and negative? And also, how can we make improvements to that plan in order to improve health? So that's where an HIA would come in. It comes in at that point, right before the plan or proposal is actually decided upon or voted upon. So you want to get in about a year before to conduct an HIA. And so really you're working to inform decision makers on the plans, and so that's what they did. And they found that making them transit-oriented developments would really improve health and walkability. And so if you're interested in learning more about that, you can read. So I wanted to just leave you with a few main takeaways and questions that you can ask your decision makers. If you're interested, you can ask them, are you considering health impacts in your decision? If so, how? Do your decisions offer healthy community design benefits? And are you making the healthy choice the easy choice through design? Thank you.
We have time for maybe one, maybe two questions if there are any.
We're trying to catch you up on time. Really good.
Yeah, perfect.
Is that slide available to us so that we don't have to run back to all that right now?
That's a question for Jay. I've had that question asked. Are the slides going to be made available? Do you have a
You guys
mechanism for
okay
it?
with making your slides available?
That's fine.
Yes.
Okay.
Yeah, we didn't ask all this pictures, so I'll try to.
Yeah.
Is it on that left?
I can
We can
email it to
download
you, or
Yeah.
I'll just
We
pull
will
it
try
onto
to
the
keep them all
the
available.
desktop.
Yeah.
I'll put it on the
Yeah,
desktop.
that's fine.
For the HIA, using the rail as example, did they reach out to you guys for you to conduct an HIA, or are they required to do an HIA before they actually start?
We didn't work on that HIA. I was just using it as an example. Jay can answer that question, but in terms of HIA, it's usually an engagement process of us reaching out to be involved. But I don't know if you know the history behind TSU, Heath, and DCM were also involved in Houston Tomorrow TOE HIA. Did they reach out to you, or did you guys just
that
do
was-
it?
Yeah, that was just that team wanted to do an HIA and wanted to study that, so it was. But in theory, the grand HIA scheme is you would want it to be integrated into the FEIS, that you would want major projects to require an HIA. So that the national effort push towards this is, we'd like that to happen.
Yeah.
And Jay,
Well,
you may know more about this now that the Houston comp plan is ready. There was at one point a recommendation in that comp plan that HIA be a standard practice. I don't know if it made it in there or not, but that, thinking exactly along those same lines, are municipalities required to conduct HIA along with environmental impact assessment? And there was definitely an interest at some point in the development of the comp plan. I don't know if it made it in or not. We'll have to wait and
Our
see.
unit that's sort of our end goal, is that
Yeah.
we're hoping to be involved through either the permitting process with our public infrastructure division, and we're still exploring the facilitated barriers of doing a policy like that. And so Raquel, who you'll hear from in a minute, is our director of Office of Policy and Planning, so we're coordinating a lot with their unit and exploring what does this look like for our county, and then if we implement something like this at the county level, which nationally I don't think, in terms of how we're exploring to integrate it into this process, is not being done anywhere else. Washington State has a similar sort of rapid health review of legislative policies that are coming down the pipeline, and so we're using that as an example to help guide our efforts. But that's hopefully where we're going, and so that would be great to be at the table for all of those permitting processes coming across and being able to put in health recommendations into that. So we're hopeful.
Do good citizens write letters to their county commissioners and judge saying they
Raquel.
Or maybe you don't have, it's not a question, but maybe good citizens could do that.
Good citizens can
We are
absolutely.
all advocates.
Our unit.
Always have the opportunity to be professional hat off.
Right.
And, show your support on something.
Any other questions? If you're interested in learning more about what our unit is doing, you can get, I have a bunch of business cards where you can ask Ellen for her contact info as well, or Jen.
And you should stay to hear about the Build Health